So this is the continuation for the schizophrenia spectrum and other psychotic disorders PowerPoint. So the next disorder I wanted to talk about was Schizophreniform disorder. And here is the diagnostic criteria for the DSM-5. So 2 or more of the following, each present for a significant portion of time during a 1-month period. At least one of these must be a delusion, a hallucination, or disorganized speech. And then grossly disorganized or catatonic behavior and negative symptoms. This should look pretty familiar to you. B, an episode of the disorder lasts at least 1 month, but less than 6 months. When the diagnosis must be made without waiting for recovery, it should be qualified as provisional. So you would call it provisional schizophreniform disorder. And then criterion C and criterion D are the same as schizophrenia. And actually, the characteristic symptoms of schizophreniform disorder are identical to those of schizophrenia. But the difference is the duration. So the total duration of the illness, including the prodromal, active, and residual phases, which I'm going to talk about in a second, is at least 1 month, but less than 6 months. So there's that duration piece again. So the Perdomo Phase, and this is applicable to schizophrenia as well. It usually starts with this phase. So schizophrenia or schizophreniform disorder would start with this phase when symptoms are vague and easy to miss. They are often the same as symptoms of another mental health problem, such as depression or other anxiety disorders. They may not seem unusual for teens or young adults. In fact, schizophrenia, as we know, is rarely diagnosed in teens and adults. Symptoms are sometimes triggered by stress or changes, such as going away to school, starting to use drugs or alcohol, or going through a severe illness or death in the family. These first symptoms often include being withdrawn, outbursts of anger, or odd behavior. And this phase can last for days, months, or years. So in the prodromal phase, it really looks like other things. It looks like depression. It looks like anxiety. It might look like an adjustment disorder. All things that are really important to know if you're working in a college counseling office, because sometimes that like late adolescence, early midlife is where psychotic breaks tend to happen. So important to look out for these kinds of symptoms. The active phase or the acute phase is sometimes called. At some point, individuals will start to have symptoms such as hallucinations, delusions, or confusing thoughts and speech. These symptoms may appear suddenly or slowly over time. They can be severe and cause a psychotic episode, which means the individual can't tell the difference between what is real and what isn't. At this point, individuals may need to go to the hospital, and unfortunately, they might not be able to make decisions about their care at this point. This phase usually lasts 4 to 8 weeks, and this is when schizophrenia is usually diagnosed, or in this case, schizophreniform disorder is usually diagnosed, so both. And then the residual phase, after the active phase, symptoms get better, especially with treatment, and life may be more normal, quote-unquote normal. This is sometimes called remission, but symptoms may get worse again, which is called a relapse. You may have this cycle of symptoms that get severe and then improve. So this is the residual phase. In each cycle, symptoms such as hallucinations and delusions may become less intense, but other symptoms such as feeling less interested in caring for yourself may get worse. The individual may have few or many cycles before they are able to stay in remission. Within 5 to 10 years, an individual may develop a unique pattern of illness that often stays the same throughout their life. It is also possible that they will have fewer relapses as they get older and may not even have symptoms at all. So moving on to brief psychotic disorder, the DSM-5 diagnostic criteria for brief psychotic disorder, so presence of one or the more following symptoms. Again, at least one of these must be 1, 2, or 3. So delusions, hallucinations, and disorganized speech, and grossly disorganized or catatonic behavior. So again, it looks like schizophrenia. Duration of an episode of the disturbance is at least 1 day, but less than 1 month. So this is very short, very brief, as it says, brief psychotic disorder. And the individual eventually returns to their premorbid level of functioning. So they have a kind of psychotic break, and then they return to their level of functioning within a month. And then the disturbance is not better explained by a major depressive episode or bipolar disorder with psychotic features. So making sure that there's not a period of mania in there before the psychotic disorder or the psychotic break, or another psychotic disorder such as schizophrenia or catatonia. and is not attributable to the psychological effects of substance or another medical condition. So in terms of schizophrenia, schizophreniform, brief psychotic disorder, it's hard to kind of tease out what's going on, especially when they are in that promodal phase and it looks like depression or it looks like anxiety. So again, as an LMHC, you're probably never going to be diagnosing these kinds of serious illnesses on your own. It would be a team approach. You'd have doctors involved and families involved. And this is like dissociative identity disorder, schizophrenia is a very specialized practice. So you will get lots and lots of training if this is something that you are interested in. Here are the specifiers for brief psychotic disorder. So with marked stressors, did something happen? And then the person had a brief psychotic episode, or without marked stressors. So the symptoms do not occur in response to any events that would be markedly stressful to almost anyone in similar circumstances in the individual's culture. So remember to keep the culture piece at the front of what you're thinking about. And then with postpartum onset, so did onset begin during pregnancy or within 4 weeks postpartum? And that, that's important to know, because then hormonal changes might be in play for a brief psychotic disorder. So the DSM wants you to specify if it's with catatonia, and we're going to talk more about like catatonic states next week, which are so super, super interesting, I think. But I'm going to go through real quick and tell you what each of these are. So number 1, stupor is no psychomotor activity and not actively relating to the environment. Catalepsy is passive induction of a posture held against gravity, and I'll give you an example of what that looks like. Waxy flexibility, slight even resistance to positioning by examiner. Mutism, so no or very little verbal response. Negativism, opposition or no response to instructions or external stimuli. Posturing is spontaneous or active maintenance of a posture against gravity. Mannerisms, odd circumstantial caricature of normal actions. Stereotypy, repetitive, abnormally frequent, non-goal-directed movements. Agitation is not influenced by external stimuli. Grimacing is with your face when you're kind of making a smile, but not really, like it's like a painful smile. Echolalia is mimicking another's speech, and echopraxia is mimicking another's movements. So I'm going to show you examples of all those in class this week. So epidemiology of brief psychotic disorder, the prevalence, the sudden onset, is defined as a change from a non-psychotic state to a clearly psychotic state within 2 weeks. Associated features of that are emotional turmoil or overwhelming confusion, rapid shifts from one intense affect to another, so I'm happy, I'm sad, I'm happy, I'm sad. Severe impairment, increased risk of suicidal behavior during the acute episode. 9% of cases, the prevalence is 9% in the U.S., most common in developing countries, more than in developed countries. There's a good question. Why do you think that is? Why do you think a brief psychotic disorder is more common in countries that are developing as opposed to already developed countries? I'll give you a second to write. And then there's a 2-to-1 ratio of females to males. Adolescent or early adulthood onset, but onset can occur across the lifespan and is most common in the mid-30s. Culture-related diagnostic issues. So make sure you distinguish psychosis from things that are going on in a person's culture that might be seen as quote-unquote normal. So in their religious background or in their cultural background must be taken into account when considering whether beliefs are hallucinations or delusions that are happening. And then differential diagnosis, so it would be substance-related disorders, depressive and bipolar disorder, other psychotic disorders, malingering and factitious disorders, which we'll talk about in a couple weeks, personality disorders, which are coming up, which are super fun to talk about, or other medical conditions. Lastly, schizoaffective disorder. Here is the DSM-5 diagnostic criteria. So schizoaffective disorder is a chronic mental health condition characterized primarily by symptoms of schizophrenia, such as hallucinations or delusions, and symptoms of a mood disorder, such as mania and depression. So you get both. Many people with schizoaffective disorder are often incorrectly diagnosed at first with bipolar disorder or schizophrenia because it shares symptoms of multiple mental health conditions. Here is the DSM-5 diagnostic criteria. So an uninterrupted period of illness during which there is a major mood episode, so either a major depressive episode or a manic episode. Delusions or hallucinations for 2 or more weeks in the absence of a major mood episode. So the delusions and hallucinations are happening when the person is not depressive or when the person is not manic. Symptoms that meet criteria for a major mood episode are present for the majority of the total duration of the active and residual portions of the illness, and the disturbance is not attributable to the effects of a substance or another medical condition. And there are specifiers in the DSM just like with schizophrenia. So you're going to specify whether this is a bipolar type, which means that the individual must have had a manic episode and they may have had major depressive episodes, or a depressive type, and that's only if a major depressive episode has occurred and a manic episode has not occurred. And listed there are the other specifiers for schizoaffective disorder. So with catatonia, first episode currently an acute episode, first episode currently in partial admission, first episode currently in full admission, and then right down the row. Let's see. So epidemiology, schizoaffective disorder is seen in about 0.3% of the population. Men and women experience schizoaffective disorder at the same rate, but men often develop the illness at an earlier age. Schizoaffective disorder can be managed effectively with medication and therapy. Co-occurring substance use disorders are a serious risk and require integrated treatment. Schizoaffective disorder can be difficult to diagnose, like we said before, because it has symptoms of both schizophrenia and either depression or bipolar. There are 2 major types of schizoaffective disorder, bipolar type and depressive type, which we talked about. Let's see, the typical age of onset, early adulthood, although it can occur anywhere from adolescence to late in life. The prognosis is better with than those with schizophrenia, but worse than those with just a mood disorder. So if you have just a mood disorder, your prognosis is better than schizoaffective disorder. But if you have schizoaffective disorder, your prognosis is better than if you have schizophrenia. So some risk factors, genetic, there's an increased risk among first-degree relatives, and it's not just first-degree relatives with schizoaffective disorder, it's those with schizophrenia, bipolar disorder, or schizoaffective disorder. Let's see, it tends to run in families, but that does not mean that if a relative has it, you are absolutely going to get it, obviously. But it does mean that there's a greater chance of the individual developing the illness. Brain chemistry and structure also play into it. Brain function and structure may be different in ways that science is only beginning to understand. Think back to the early research that we talked about on schizophrenia. So brain scans are helping to advance research in this area. Unfortunately, those scans are done post-mortem, so after the person has already passed away. Stressful events such as a death in the family, an end of a marriage, or a loss of job can trigger symptoms or the onset of this illness. And drug use. So psychoactive drugs such as LSD have been linked to the development of schizoaffective disorder. So do not do LSD. Suicide risk, the lifetime suicide risk for individuals with schizophrenia and schizoaffective disorder is 5%. And the comorbidity that is seen with schizoaffective disorder a lot of times are substance disorders, anxiety disorders, and then a higher incidence, that's supposed to say medical conditions than in the general population. So this is a lot of information. Again, schizophrenia is fascinating, and there's a lot of research about schizophrenia. There are a lot of opportunities to conduct research for schizophrenia. So we will talk about research opportunities next week in class, and we'll also look at a bunch of clips, some therapy sessions of individuals with schizophrenia and what each of the symptoms look like. So just be sure to finish up the assessment piece and not to get freaked out by all the information on these PowerPoints. All right, thanks.